So from the bacteria back to the most important and second most important organ, the brain and the heart, and we can discuss which is more important depending on the time and the specialism of the person you're talking to. But we often don't have to choose because, as I will show hopefully to you in the next 45 minutes, the two are very closely connected and can influence each other. And I hope in the next 45 minutes to make you look at several aspects of care in a little bit of a different way. Hopefully also keeping you awake a little bit. It's been a long day. And the question we have to ask ourselves is why we need to have a special consideration, why things are different in patients with brain injury from a hemodynamic standpoint. And there's a couple of reasons for that. The first is that we see a lot of arrhythmias and a lot of blood pressure problems. Arrhythmias also linked to electrolyte disorders in patients with brain injury. And the reason, as I will show, is that the brain injury itself causes these arrhythmias and causes these problems with blood pressure, as well as electrolyte disorders. And unfortunately, patients with brain injury have a much lower tolerance for these blood pressure variations and for these arrhythmias than regular patients. My former boss used to say, and I quote him with agreement, the injured brain does not forgive. You cannot get away with the things that maybe in other patients you can get away with in terms of hemodynamic management in a patient with brain injury, because if you get it wrong, then the patient will suffer and often will suffer permanent injuries, which is not so quickly the case in patients without brain injury. So it's of key importance to maintain homeostasis in brain injured patients. And I will talk now about blood pressure, but it applies to other aspects as well. And this is an image which kind of captures the situation of a brain injured patient in the ICU being threatened from all sides in a kind of perfect storm. So it's not just the blood pressure and the arrhythmias, though that will be the focus of my talk, but it's also a lot of other aspects of the milieu interieur of homeostasis. You need to avoid hypoxia and hyperoxia, and you need to avoid hypocarbia and hypercarbia. And I will show, although it's not the topic of my talk, I will show two examples of why that is vitally important. We talked a lot already about fever. That needs to be avoided. We need to avoid disorders in electrolytes for reasons that I will show a little bit of, and other situations as well. And you can't say that if you get one thing right that the others don't matter. All of these are important. So you're wondering maybe hypoxia, yes, we know it's a problem, but hyperoxia, is that a problem? Well, yes, maybe too much of a good thing is not so good. This is a very large observational study in patients with cardiac arrest and post-hypoxic brain injury, more than 6,000 patients, and these authors found that both hypoxia but also hyperoxia was associated with adverse outcome. And you can postulate on mechanisms, possible more free radical formation or more oxidative stress. We don't know. Maybe it's a fluke. It's not a proof definitive that this is a cause and effect, but it's suggestive. It persists on multivariate analysis. So maybe too much of this good thing can actually harm our patients. So too high and too low CO2 levels. This is a patient with traumatic brain injury, and this slide was given to me by my friend David Menon from Cambridge, and they have a CT scan device and a perfusion scan right in their ICU, so they can very easily transport the patients for these studies. And this is looking at the perfusion of the brain. The areas marked red here, they're normally darker, are areas that are hypoperfused, that have less than 20 milliliters per 100 grams of brain tissue. This is the threshold below which, it's actually 80 milliliters below which ischemia occurs at normal temperature. And below 10 milliliters you get necrosis. If you have a lower brain temperature, the numbers are a little different, but there is a threshold. So here is this patient with several areas at risk. Now they hyperventilated this patient for 10 minutes to this CO2 level, and they repeated the scan, and this is what it looked like. Now, I can't imagine that this is going to be good for an injured brain, and especially not if you do it by accident. If you're bridging the patient because he is herniating and you're taking him to the OR, by all means you should hyperventilate, but you don't want to do this by accident. I'm sure some of you are thinking that I took one really bad example and I'm showing that to you, but these authors did 25 patients consecutively, and this is the local threshold, the local hypoxia of the brain, and about half of their patients went under the threshold and all of them showed this phenomenon. And in fact it might be worse even than that, because in a subsequent study, this is the global perfusion, and but in a subsequent study the authors focused more specifically on injured brain areas, on ischemic brain areas, and they found that this effect of hyperventilation was more predominant in areas that were already injured. So if you have ischemia and you hyperventilate the patient, the ischemic areas get even less perfusion than the rest. So this is really a problem, and this is really an avoidable problem if we are managing our ventilators not well enough and doing this by accident. So we talked about fever, just one example in cardiac arrest where we don't usually focus so much on what happens afterwards. This is an observational study, very large study though, and finding that having episodes of high fever is associated with a huge drop in the risk of or in the chance of good outcome. Going from here in hospital arrest patients, more than 80% good outcome if they survive the initial insult, to less than 40% if they have a high fever episode. So this is really also something which is a very powerful correlation. Electrolyte disorders, this gets me a little bit towards the real focus of my talk, because it's associated with arrhythmias, but it has probably direct effects too. Just one example with sodium. This is a huge study, almost 100,000 patients, finding that the 1-year outcome in patients who develop hyponatremia is 50% worse than patients who don't have that problem, and even 5 years later you still see this effect. This is on multivariate analysis, corrected for all other factors. Again, these observational studies can't conclusively prove that it's cause and effect. That would be very difficult to do in any case, but it's highly suggestive. The injured brain does not forgive. The injured brain does not like abnormalities in the surrounding areas, and it's our job to prevent those and to make things as normal as possible. So what about blood pressure and arrhythmias? First, we have to look very briefly at the concept of cerebral autoregulation. Stefan already discussed it in his talk, so I can go through this very quickly, but it is relevant to what I need to say next. So as Stefan discussed, there is a broad plateau in non-injured brains and in normal patients where the brain protects itself from hypo and hyperperfusion by dilating and constricting the blood vessels to the brain. So in this wide range, usually between about a mean of 40 and a mean of 125, the brain is protected from the effects of too low and too high blood pressure. If a patient has chronic hypertension, two things happen. The curve shifts to the right and the plateau becomes smaller. So right there, this patient has a lower tolerance for hypotension, and the room for maneuver is smaller in these patients because the plateau is smaller. And of course, some of our patients with acute brain injury, or many of them, lose the ability to autoregulate, and then the brain becomes very susceptible. Every change in blood pressure leads to a change in perfusion. And too high blood pressure can lead immediately then to hypertensive encephalopathy, and too low blood pressure can lead immediately to ischemia, and both can cause permanent injury to the brain. Both too high and too low can be harmful. This applies to everyone, but it applies to brain injured patients much more so, and they have a much lower margin, so we have less room for maneuver, especially in patients who lose the ability to autoregulate, and injured brain areas are more susceptible still. So this is really a problem. And unfortunately, the brain injury itself is associated with, and as I will show you, can cause all kinds of problems that can lead to hypo and hyperperfusion. It can lead to myocardial dysfunction, and this has been shown for subarachnoid hemorrhage, for intracranial hemorrhage, traumatic brain injury, and ischemic stroke. Arrhythmias and tachycardia for subarachnoid hemorrhage and TBI, likely also the others, but it's not been shown conclusively. Electrolyte disorders, vagal nerve dysfunction. So Dr. Schmutzhart talked about the risk of infections. Because of this problem, our patients are at higher risk for infection already, because this vagal dysfunction can cause immune suppression and can cause malfunction, less activity of white blood cells, and this in itself puts our patients at higher risk for infections. It really is the perfect storm for our patients. Looking at the myocardial dysfunction, this has been most well studied in subarachnoid hemorrhage, and this is a well recognized entity, Takotsubo cardiomyopathy. We'll come to the name in the next few slides. So around 20 to 30% of patients have this in more severe form, so severe that we notice it. If you look at the patients more closely, if you do ultrasound in all of them, then you see that the number actually is a lot higher, but not all patients become symptomatic. In about 20 to 30% it becomes a significant problem, and we notice it. And the higher grade aneurysm the patient has, the higher the risk that this myocardial dysfunction will occur. And it's linked to the severity of injury, also to the gender. Females are at higher risk than males, and it can be predicted by troponin leak, which happens a lot in these patients. This is the first paper that reported this in the American Journal of Cardiology by a Japanese group. That's why the name is Takotsubo cardiomyopathy. The heart in this particular patient, as described, was ballooning outward in this very particular shape. And to the eye of this cardiologist, it looked like this. This is a pot that Japanese fishermen used to catch octopus. The father of this cardiologist was a fisherman, and so he knew this pot, and that's why he called it, gave it that name, and that's why we call it Takotsubo cardiomyopathy. So this is the typical shape, but we're now learning that it's not always so typical. This can have all types of myocardial dysfunction. It can have from complete akinesis, so global dysfunction of the whole heart, to something that mimics very much an acute MI, a myocardial infarction, because it has a regional abnormality. And this large case series of 107 patients looked at this and found really all types of myocardial dysfunction and all kinds, and here are some examples from that study of what the heart looks like. So it's not always typical, it doesn't always look like this octopus pot. Work on my own fluid management, apologies. So, and it's not just in subarachnoid hemorrhage. So when this was first reported, it was thought to be extremely rare. It was a case report like this never happens, and we now know it happens a lot. And we're seeing this now more in other types of brain injury as well. It's been seen in hydrocephalus. It's been seen in patients with just seizures, no other brain injury. In Guillain-Barré syndrome, cerebral contusions, in ischemic stroke and hemorrhagic stroke, so intracranial hemorrhage, all case reports, all anecdotal, and it's probably not as frequent as a subarachnoid hemorrhage, but we haven't looked at this systematically, and we probably should, and there's probably more patients who have this than we think in these other types of brain injury as well. And this can happen regardless of age. So this is the strange thing, that you get someone, a healthy 20-year-old who was doing fine this morning, has a subarachnoid hemorrhage, and then comes to your ICU with a myocardial dysfunction. And here is a case report from a 2-year-old girl who has this issue. So this can happen in everyone, and not only in brain injury. I'll skip in the interest of time. And this is likely, we're not sure, but this is likely caused by the huge outpouring of catecholamines, of epinephrine, adrenaline, at the moment of injury, of the stroke, of the bleed. And one very elegant proof of concept is this study, a case series published in 2005, demonstrating two things: that you can actually get a case report published in the New England Journal of Medicine if it's good enough, but also demonstrating that you can get reversible myocardial dysfunction from acute emotional stress, leading to the catecholamine surge and giving rise to a syndrome which looks very much like this cardiomyopathy related to brain injury. And so there can be severe stresses like death of a close relative, but here surprise reunion, surprise party, not such a huge, fear of procedure, interesting for us as physicians. And as you can see, I'm at risk too, standing here, so if something happens, you know what to do. All these patients were thought to have an acute myocardial infarction, and they all had coronary angiography, and they had clean coronaries. These are EKGs from some of these patients, looking very much like coronary ischemia, and this is very similar to what we can see in subarachnoid hemorrhage patients with the EKG abnormalities, the wall motion abnormalities, and this was all fully reversible. A few weeks after these events, the patients were fine, the heart was working normally, and, well, no harm done. So if this is all reversible, does it matter? Why should we look at this? Why am I talking about this? It all goes away, it's temporary. Well, this is a problem because we are trying to manage these patients. We're doing all kinds of treatments with them. We're giving them all kinds of drugs to raise blood pressure maybe, and this is a problem if the patient has myocardial dysfunction. And Stefan Meyer's group has looked at the link of this myocardial dysfunction to outcome, and they found that patients who have this reversible myocardial dysfunction nevertheless tend to do worse, have a higher risk of vasospasm and infarcts from vasospasm. And this makes sense because you cannot manage the hemodynamics as effectively. You can't raise the blood pressure as easily to increase brain perfusion if your heart is not working. So this affects our treatment. So if we do Triple H therapy for subarachnoid hemorrhage, this is back from my time in the Netherlands, a young patient who came in, a young man, 25 years old, and a few days later his chest x-ray looked like this. And this is basically someone, I said, who has a very healthy heart, but this makes the therapy all but impossible. Many of the treatments we give to protect the injured brain can make this worse. If we give lots of fluids to such a patient in myocardial dysfunction, we can put them in complete heart failure, and then the bets are off. We cannot do what we need to do for them anymore. Fortunately, this syndrome is often quickly reversible, but sometimes it lingers and then it's a problem. EKG change and arrhythmias even more frequent in subarachnoid hemorrhage. If you look closely, up to 90% of patients have them, and this is an example of what this then looks like. And these patients sometimes get mistakenly identified as acute MIs and even get taken to the cath lab, and sometimes in the past even got TPA before it was figured out that they actually had a brain hemorrhage. So, this is again a very frequent occurrence. And when these patients are in the ICU, I don't know if you're rounding in a patient with subarachnoid hemorrhage, the normal values kind of shift. Most of these patients have a heart rate of about 100. And this is not normal. It's actually tachycardia, but we're so used to seeing it that we kind of think it's normal. But this is actually, it's higher than their baseline. It's often our healthy young people, and it's caused likely by the hyperadrenergic syndrome, having these patients in a sort of continuous state of stress. So they had the initial outpouring of catecholamines, but they remain in this kind of hyperadrenergic state. And this can cause tachycardia, hypertension if the heart is working still well, and arrhythmias. And this happens in subarachnoid hemorrhage, but also in other types of brain injury, in particular in traumatic brain injury. And this again is related to the brain injury directly, likely through the vagal nerve. I talked already about the effect on the immune system. Really fascinating that this happens and puts our patients immediately at risk for infections, but this also can directly, of course, affect the heart, because that's how the brain controls the heart rate. And if this is malfunctioning, your heart rate also can malfunction. And in traumatic brain injury, this has been shown most clearly, this increased vagal tone, which then leads both to arrhythmias, but also to increased susceptibility for infection. So I talked so far about catastrophic and major brain injuries, but this can happen even in elective surgical procedures. So in cardiac surgery, it's logical. We're operating the heart and we're manipulating it, so this causes arrhythmias. But actually, neurosurgical interventions also frequently trigger tachycardia and arrhythmias. And the summary of the literature on this is given here. So perioperative hypertension is very common in the hours around neurosurgical interventions, and tachycardia and new onset AFib occurs in around 2% of elective cases and about 8% of emergent cases. And the perioperative hypertension has been linked to an increase in risk of intracranial hemorrhage. And this is particularly true if the patient did not have hypertension previously. If there is a new onset hypertension, then the increase in risk of hemorrhage is much greater than if the patient already was known with hypertension. But if it's not well controlled, if there is an episode of hypertension around this neurosurgical procedure, then this can lead to intracranial hemorrhage, and this is all highly statistically significant. And this is the largest study looking at the incidence of new onset AFib in elective neurosurgical procedures. So in catastrophic brain injury, almost all patients have this problem, but even in elective surgery, you can get this. And then there are the general issues. So I talked so far about the direct effects of brain injury on the heart, but there's the other factors. The patients may be not young, but they may be old. They may have underlying conditions like sick sinus syndrome, which has not been a problem so far, but in the situation where they're in the ICU, then this will manifest itself. Then there is the stress of staying in the ICU. We're very good at making ICUs as uncomfortable for patients as possible, starting with the 4 o'clock in the morning CT scan so the neurosurgeon can see it at 6 o'clock, to all the noises, all the alarms, all the beeps, all the machines that we have which disrupt the patient's sleep. It's a recipe for inducing delirium, topic for a different discussion, but it also can cause cardiovascular stress, which can add to the risk of arrhythmias. The patient may have pain. We're always in discussions with our neurosurgeons about patients with subarachnoid hemorrhage. They have severe headache, and we want to have the neuro exam, and the neurosurgeons prefer to give the patient no pain medication except paracetamol. But if you don't do that, then you increase the psychological stress, the tachycardia, and the risk of arrhythmias. So this is a dilemma. And many of our treatments can add to the problem. Vasoactive drugs can lead to electrolyte loss and can trigger arrhythmias, especially dopamine, which I don't like to use anyway, but this is an extra reason. Antibiotics, such as piperacillin, can lead to increased electrolyte loss and thereby trigger arrhythmias. Hypothermia we talked about. I'm a fan, obviously, but if you cause electrolyte disorders, this can lead to arrhythmias. Almost all our patients have some degree of tubular dysfunction in the ICU, which puts them, again, at risk for electrolyte disorders, which can then trigger arrhythmias in this already prone population. This is just an example of the many sources of electrolyte loss in the ICU. The example is magnesium, but I could put potassium too, and you see all these factors like having a nasogastric tube, which all together work to inducing electrolyte disorders in these patients, which can then trigger the arrhythmias, which can then cause permanent injury. So this is all a lot of physiology and a lot of fundamental stuff. What about the clinical evidence? Because we want to have evidence-based medicine, but fortunately we have a lot of evidence, a lot of studies showing that hypertension, and I'll get to hypotension later, can independently predict adverse outcome in brain injury. And it's been shown most clearly for intracranial hemorrhage and ischemic stroke, but also for the many other types of acute injury that we see. It's not been studied well in post-hypoxic injury and encephalitis, so we don't know the answer there. All the others, the answer is yes, and I'm going to show you some examples. This I already showed you, the risk of intracranial hemorrhage with perioperative hypertension. This is a really interesting study from a large database in trauma patients. So we've always focused on preventing hypotension in these patients, and indeed hypotension was associated with higher mortality in this group. But hypertension, almost the same effect. So there is an optimum value apparently of blood pressure, of mean arterial pressure, and if you go too low it's bad, but if you go too high it's also bad. So in intracranial hemorrhage we have the most research looking at interventions to treat blood pressure. We don't have a final answer yet. This is an ongoing study, the ATTACH study, looking at 3 target ranges of blood pressure. A little bit control of blood pressure as currently recommended in guidelines, more strict control of blood pressure, or very strict control of blood pressure. The preliminary results of that study, not significant yet, they have 400 patients enrolled, are that they had a very clear trend to reduction in the increase in size in hemorrhage. P-value just failed to reach statistical significance, but this looks as if the intervention is effective in reducing the increase in size. The other study that's going on, much smaller number of patients, actually didn't find that and found a slightly increased risk in of increased bleed. So we don't have the final answer yet, and we'll get to the risks of hypotension in the next few slides, but it looks as if managing being aggressive with blood pressure in this indication is good, but we're not sure yet. After neurovascular interventions, meaning stenting, opening of cerebral vessels, about 4% of patients can get a hyperperfusion syndrome when this happens, and this is a perfusion scan showing an example of that here. And this can be managed by treating blood pressure. This is a list of studies looking at this, fairly small studies. This is a review summarizing a lot of those and finding an average rate of between 2 and 4%. And this is another review finding a rate of about 2%. So 2% of patients where you stent can get this hyperperfusion syndrome. What about stroke? In stroke, I said the answer was yes, and here we have really large observational studies, look, almost 18,000 patients, showing this linear increase in risk of adverse outcome with increasing blood pressure. And it looks from this study that the best is this. But I'll show you that this differs between different patients, and this difference is related maybe to age and other factors. Well, we looked at hypertension. What about hypotension? Well, hypotension obviously also is associated with bad outcome. For traumatic brain injury, we already saw this study. I'm going to go through this a little bit more quickly. So I showed you this slide before. What I left out a little bit, that's this here, showing that hypotension also is associated with worse outcome. And in fact, the increase in bad outcome is about 4% for every 10 millimeters mercury increase in blood pressure above 150. But if it's below, that's 18%, so more than 4 times as much. And this very elegantly illustrates the point: hypertension is bad, but hypotension is probably worse. And many studies have shown this U-shaped curve. And as you see here, the right number in this study is between 160 and 180 systolic. And it depends on the pre-existing condition of the patient, whether they were hypertensive, how old they are, etc. So we can say in this very large pool of 18,000 patients, the right number seems to be 150 systolic, but we don't know that this applies to each patient. Hypertension is bad, hypotension is worse. And this is also confirmed by this review, looking at observational and intervention studies where blood pressure was managed in these patients, where blood pressure was lowered. And the bottom line is that some studies reported that this improves outcome, some studies report that this makes no difference, and some studies report that this makes outcome worse. And the reason very likely is that all these different patients have individual blood pressure targets, and what works well for one might actually harm the other. And there is no good recommendation to give what the right target should be in everyone. And that's underlined by these reports of ischemic stroke that was caused by our interventions, by too aggressive blood pressure management. And that's, of course, that's a disaster. If you're treating a patient, you're giving an antihypertensive, and then you cause a stroke, that's terrible. So I'm going to skip this one as well. I'm going to show just this data, too aggressive blood pressure management. This is also from Stefan Meyer's group looking at the effect of overshoot. And in this database, it looked as if excessive hypotension resulting from intravenous treatment was associated with worse outcome, and this is a big effect, but it wasn't statistically significant. Nevertheless, and I would agree with that, it really looks from this database as well that excessive blood pressure reduction can contribute to poor outcome in patients with severe brain injury, and this is in different types of brain injury. So I'm leaving you a little bit like this. Like, I'm telling you that you need to manage blood pressure and you have to be alert and the patient needs the right number, and then I'm telling you, but hey, if you treat intravenous and you overshoot, then you will harm your patient. So what is the take-home message? Well, the solution is that we need to get things just right. We have to have the right individual target in each patient. This applies to blood pressure, but to other aspects of intensive care as well. We need to have the right dose and the right drug for each individual patient. And this applies also to sedation and to antibiotics and to everything that we do in the neuro ICU. The first thing to do is to do no harm. And I'm not brilliant, and I get things wrong all the time, so I like in these unstable patients to use short-acting agents. So if I overdose or if I get it wrong, I can stop the drug and the effect goes away, and I don't harm the patient. So, for example, using clofidipine or esmolol rather than a long-acting agent until I know what the effect of the drug will be, and then I can transition to longer-acting drugs. And for sedation, if the patient can tolerate it in terms of myocardial function, propofol rather than benzos, etc., etc. So short-acting agents so that if you do get it wrong, the effect goes away quickly. And there is no standard recommendation on which drug you can always use. It depends on what's going on with the patient. Does he or she have myocardial dysfunction or not? Is there a problem with tachyarrhythmias or bradycardia or not? And that determines which drug you should use. One drug which you should never use is nitroprusside. This has been shown to increase mortality in various populations. It can decrease cerebral perfusion. It can increase intracranial pressure. There's lots of reasons to not use that drug, even though it's a very powerful one, and there are plenty of alternatives. What you should maybe use is a beta blocker. And this is already quite an old study, a small study, but looking at the effect in subarachnoid hemorrhage of beta blockade. And in this small study, they found a beneficial effect. And this has kind of been repeated a couple of times, but never been conclusively proven. And we should look at this a little more closely, I believe. This is in a database from traumatic brain injury, also finding a link with use of beta blockers, which are potentially protective. It's not proven beyond reasonable doubt, but this is something interesting to look at. So when to use which drug depends again on the severity of hypertension, the risk of overshoot, if the patient has tachycardia, bradycardia or not. And finally, you can also take into account the possible effect on cerebral perfusion. There is evidence that calcium antagonists increase cerebral perfusion, where beta blockers don't have that effect. Is that a good thing? Well, it depends what's going on with the patient. If the brain is hyperperfused, a calcium channel blocker would seem like an excellent idea. If the brain is hyperperfused, maybe it's not such a good idea. Beta blockers don't have that effect. So if there is hyperperfusion, a beta blocker might be better. So we need a tailored approach to our individual patients. And I'm going to end with something, a question which underlines that we have to cover the basics first. I'm going to give an example, and I'm going to ask you to vote on 5 possible treatments. So this is a patient who's undergone back surgery. The case was complicated by bleeding from the surgical wound, and the patient is taken back to the OR, and he gets anesthesia with propofol and remifentanil, which is a short-acting opiate. I don't know if you have it here or not. So they find the source of the bleeding, they repair it, they stop the sedation, they take the patient back to the ICU, and then you're called because the patient is agitated, and his blood pressure is high, his heart rate is high. He is in sinus rhythm, so you're asked, okay, what to do about the hypertension, because it's above the set target. So the choices I'm going to give you is to give the patient a long-acting beta blocker, to give the patient a diltiazem, calcium antagonist, to give the patient a short-acting beta blocker, to do nothing at this time. The blood pressure is acceptable, patient is in sinus, so we just wait. Sedate the patient with either propofol or a benzodiazepine. Give the patient haloperidol because he seems to be agitated and probably delirious, or give the patient fentanyl or morphine. So who would like to give a long-acting beta blocker? Abstentions are not allowed. You have to pick one answer. Who wants to give diltiazem? No one? Who wants to give a short-acting beta blocker? Okay, a couple of votes for the short-acting beta blocker. Who wants to do nothing? No one wants to do nothing. We're intensivists. We want to do stuff all the time. Who wants to sedate the patient? Okay, that's a majority for sedation. Stefan wants to do both. He's really aggressive. Who wants to use haloperidol? And who wants to give fentanyl? Okay, that's a small minority. I think fentanyl is the right answer. This patient just had his back cut open, and then he was treated with short-acting stuff, and he's back. This patient is probably in agony, and he's trying to say that, give me something for my pain, but he's intubated, so he can't. I would get agitated too. Don't forget the basics. Don't give antihypertensive if pain is not sufficiently controlled. And if you give sedation to someone in pain, you increase the risk of delirium. So don't be this person, and don't let your patient be this person. So this brings me to the end of my talk. In conclusion, the injured brain seems to be, I still have my conclusions, and I have one more movie for you. Seems to be far less tolerant of disturbances in homeostasis in general. I focus on blood pressure, but others are equally important. Getting the basics right is even more important in these patients than in other categories of patients. We need to do everything we normally do, but we need to do even better. We have to be top-of-the-line intensivists and neuro people, and we have to do everything really, really well. Avoiding hypoxia and hyperoxia, hypertension, avoiding all these disruptions, and taking care of the patient in the optimal way. So, if unless we're brilliant at predicting the effect of every drug, then we use short-acting agents in these patients who are unstable, and then transition to longer-acting drugs once we've assessed the effect. And there should be an individual target. The 20-year-old with subarachnoid hemorrhage is not the same as an 80-year-old with subarachnoid hemorrhage. It's an obvious observation, but it's something we don't always take sufficiently into consideration. And these patients, as I showed you, are at high risk for getting arrhythmias and blood pressure swings due to the nature of their brain injury. Does it all matter what we do? Does it all matter, all these small things? I think the answer is yes, and we fortunately have some scientific evidence to back this up. So we talked this morning about the procedures in Australia, where patients are always taken to the closest hospital, and the same is the case in Britain. If you have a brain injury, traumatic brain injury, you get taken to the closest hospital. Some hospitals are designated trauma centers, others are not. Doesn't matter, you go to the closest hospital. And they looked at the outcomes of these hospitals. Now, every hospital there works with the same protocol, so they should be giving the same therapy. They treat brain injury exactly the same. Nevertheless, the outcomes varied by more than 100%. The trauma centers had more than twice as many good outcomes as the non-specialized trauma centers. And they have the same protocol. So what explains this difference, which persisted year by year? Well, it must be all the small things that we do better in specialized centers. We pick up a little bit earlier on the blood pressure, which is before it crashes. We are maybe better at treating the infections and at de-escalating the antibiotics, picking up on the small signs before disaster strikes. So even when you're working with the same protocol, this does make a difference. So the answer, does it all matter? The answer is yes, we can and should do the best job we possibly can. But never forget that in brain injury, prevention is better than cure, which is demonstrated by this short movie. Hopefully it will work, and the sound will work. I have to click on it, I forgot. Fantastic. So what's the lesson here? This unfortunate patient not only suffered severe brain injury, but chose a very bad place to do it. So make sure that your hospital is not one of those places. I want to end with that, and thank you for your attention.